for the lovely welcome. Dr. asked me to speak a little bit about the post-acute care and put it in the context of what's going on nationally in terms of healthcare reform, because there's a lot going on, and it affects all of the different healthcare communities, the OTs, the PTs, the physicians, the nurses, the hospitals, all of the different types of providers, the rehab hospitals, the long-term care hospitals, the skilled nursing facilities, home health. So I'm going to give you kind of a crash course, put in a lot of the words, the jargon that's being tossed around right now in the context of the bigger picture. This is, of course, assuming I can run technology. So here we go. So today's evolving healthcare environment. How many of you have looked at the Affordable Care Act mandates? Okay, so it does a lot of things, and it's been very controversial. There's a lot of insurance changes. There's a lot of new IT things going up. But what it really does is drive home a person-centered focus on healthcare. So it's no longer just about cost containment. It's about the person and about managing the costs across that person's entire episode or broader, their use. But it's different than other approaches in the past because the focus is on improving quality of care. And the argument is that if you can improve the quality of care, much by better coordination across the different parties that are touching that person, then you can improve population health, and in effect, the costs of care will come down. So everybody wins. The clinicians win, bankers win, the businesses, etc. So this focus on the patient-centered care has really underscored the need for setting agnostic metrics. So we're no longer talking about hospital treatment, hospital costs, hospital outcomes. We're talking about patient care, and one of the places they went was the hospital, and let's think about their outcomes across their trajectory. In complement to this, there have been congressional mandates under the Medicare program to now monitor quality, to report on quality, regardless of what type of Medicare participating provider you are. So early on, the hospitals had a quality mandate, and how many of you are familiar with the readmission hits? Yeah. So everybody knows about readmission. There's been a lot of work here on readmissions, very good work, very applicable across the board. But it's just the beginning. So right now, the hospitals have a readmission policy. The other providers are getting readmission policies. The federal government is trying to figure out what are the other appropriate quality metrics that should be used. And the innovative payment methods that are going into place are pulling in these quality metrics. So as we hear talk about things like bundled payments or medical homes or accountable care organizations, they're all offering an incentive to the clinical community to improve the quality of care and improve the population health. If that reduces the cost of care, then you'll get to share in some of the savings. But in order to do that, you have to hit the quality thresholds first. So quality metrics are pretty important in today's world. So just as an example, in both the public and the private sector, we see quality adjustments for hospital readmissions just in the basic fee-for-service world. You don't have to be in any of these demonstrations or initiatives. The hospital payments are going down if their readmission rates are too high. Shared savings, accountable care organizations, gain sharings, medical homes, bundled payments, value-based payments, all kind of jargon, but basically saying the same thing. If you can improve the quality of care, which effectively will reduce the cost of care, then we will share with you some of the savings. And how much that savings might be depends on the actual program, and I'm happy to go into that later if there's questions. But why care? These next couple slides just give you a little context, because we always talk about Medicare, Medicare, Medicare. Well, we're talking about almost 47 million people, and a pretty substantial portion are probably getting services from the allied health community, from the OTs and the PTs. You have 17% who are on Medicare but are under 65 years old. They're there because they have a disability of some sort, and they've qualified for at least 2 years on the disability benefits. So that's a pretty substantial group that can be pretty expensive. Then you have the group that everybody thinks of, that 80 years old and older, which you see is only 22%. So you're only talking about a quarter of the populations. And when you're thinking about the costs that people accrue to the insurer, they differ across those four groups. So that was a lot of people. It's even more money. $331 billion, that's with a B, $billion were spent on Medicare in 2010. And this distribution of how they're spent is kind of interesting because when I started in this field 20 years ago, the hospital accounted for 60% of the Medicare dollar, and now it's down to about 40%. So we've seen a lot of changes over the last 20 years in terms of the use of the different settings. It's not the relative payments because hospitals still get a big chunk of the dollar per service. The physicians, they've increased a bit. They used to be around 20 to 25%. Now they're up to almost 30%. So you hear a lot of discussion. The SGR discussion hit Texas. Yeah, okay. That's why. It's an increasing proportion of the Medicare dollar. Outpatient services, 14.4% of that $331 billion. Skilled nursing facilities, 8.2% of the dollars. But you'll see when I put up some other numbers, these are really high. A lot of the bennies are using the SNF services, but because of the lower cost per service, they account for a smaller piece of the pie. And similarly with home health, which is even less expensive per case, and hospice. Hospice is an interesting area because, again, when I started, it was 0.1% of the Medicare dollar. And now it's up to almost 4%. You're really talking about palliative care. You're not talking about inpatient costs. So there's some real shifts going on in how we treat patients. So what types of services are being used? Well, again, to put it in perspective, 1 in 5 Medicare bennies are going in the hospital every year. And they're admitted for all sorts of things. They're admitted for simple medical issues, for surgical, or for functional diagnoses. And this all comes out of a report you can find on the web that we did back in 2009, looking at service trajectories. What are they using? Well, about 35% of those discharges, so you have 1 in 5 bennies going into the hospital, 35% of them coming out are going on to post-acute care. The majority are either going to a skilled nursing facility or to home health. A smaller proportion are going to inpatient rehab hospitals, and a near equivalent portion to outpatient therapy, either in the clinics, the therapist's office across the country, and another 2% to long-term care hospitals. Yep. These percentages are of the percent that came out of the hospital and did not go immediately home without services. They could have. Yep. And that was an excellent question because when we talk about patients' episodes, one question you always want to ask is where are you starting that episode definition? And it goes back to all of these initiatives that I mentioned before. They all have different definitions. And it was pointed out earlier, there's a report out on the ASPIA website. No, MMRR publication just published a paper that we did looking at what happens if you define an episode as a hospital stay plus 30 days, or a hospital stay plus 60 days, or a hospital stay plus 90 days, or it starts in the community, so you're not and we showed the difference in the cost calculations and the probability of using the different types of services and how that varies by the different types of cases. So everything, as the epidemiologists in the room know, vary by the case mix complexity. But they aren't just using that one service. That group that goes from the hospital into the different settings, most of them are going on to use additional services within that first 30-day window. So you're not just talking about a hospital to skilled nursing facility. 60% of them are going on to either home health or outpatient therapy, or about 20% are going back to the hospital. And I have some other graphics that show some of those trajectories. But it was work like this that showed how important the readmission policies are. Because on average, I think the Medicare number was 30% of all bennies will have a readmission rate. And when I looked at it by the different types of reasons for hospitalization, there's real variability, with the rehab populations having the lowest rehospitalization because generally they're the healthiest, but the medical populations having much higher, and that varied by reason. So as an example, this just gives you a bit of a decomposition. So that first row is the acute hospital to the home health. Remember, we had about 37% that went to home health. Only 23% ended their services there. If you go down to see if I can use this, down to here, you see that out of those cases that went on to post-acute care, 4.5 went from home health back to the hospital. That's quite a few people when you bring it down to a people level. Skilled nursing facility, out of that 45% that went to the skilled nursing facility, 3% went from the acute to the SNF to the acute to the SNF. So there are some real patterns that vary, and there's a lot that can be explained. So in 2005, Congress mandated that CMS set up a post-acute care payment reform demo and really look across the silos of care to understand how these patients differ, if they differ, and whether the cost differences made sense. So to do that, we had to set up a single comprehensive assessment tool because the world in 2005 used all different assessment tools. Everybody has one. Everybody's assessing the patients when they're admitted to the hospital or going into a SNF or anywhere else, but they're all using different language. So CMS was charged with standardizing that to measure health and functional status and other treatment factors. So I'm going to talk a little bit about the development of that standardized item set because it's very important as we're moving into the policy debates today and still trying to figure out whether the payment rates are appropriate, whether the outcomes that we're seeing make sense, or whether there are just uncaptured differences. So my team was quite huge. We had members from the Rehab Institute of Chicago, members from the Visiting Nurse Service of New York, RAND, Case Western, Pennsylvania, all coming together. I had clinicians on the team who had different backgrounds, from the geriatricians to the social workers and everything in between, as well as experience in different levels of care, because even if you're talking to a nurse in a hospital, they're using different language than the nurse in the nursing facility. So we needed to really look at these issues and try to create some consensus about what is the appropriate language. This slide just talks about what was going on at that time. So all of these assessment tools, whether you're being admitted to a hospital or in a SNF or a home health agent, they're all measuring the same thing. They're all measuring the patient's medical complexity, their motor functional status, their cognitive status, their social support and environmental factors. But there are some key differences. They're using different items. So the simplest of examples is a pressure ulcer. You have a patient coming out of the hospital with a pressure ulcer, and that nurse is saying it's a stage 3. They're going over to the SNF, which thinks that they can deal with them, but lo and behold, it's really a stage 4. And just a difference in the measurement practices, and you have all of that discussion at the hospital discharge site. So the items that measured the concepts differed, the rating scales differed, the look-back assessment periods differed, and in some cases the science, the unidimensionality of the items differed. So the next couple slides just give you examples from the functional status measures in the 3 federally required tools as compared to the consensus-based care item set. So how many of you are familiar with the FIMS, your PI instrument? Okay, this is a federally mandated set of items that are used in the inpatient rehab hospitals to measure functional complexity and to some degree medical complexity. And they use a 7-level scale to measure how complex the patient is on 18 different factors, some of which are mobility, some of which are self-care, some of which are cognition. MDS is the mandated tool in the skilled nursing facility. So any Medicare, Benny, or Medicaid admitted to a SNF has an MDS completed on them within the first 5 days, 14 days, 30 days, 60 days. So different periods to measure their complexity, and they have a system where they look at the patient's ability and their support needs. So they're tracking 2 factors about the patient. OASIS, they have 8 different items in all different scales. So CARE was trying to standardize that. Everybody uses the Barthel Index. The point is, how do we do that in a consistent manner? So this scale just sort of compares the rating scales. You see things like in the rehab community, you go from most dependent at the bottom of the scale up to most independent at the top of the scale, whereas in the nursing facilities, they went the other way. OASIS depended on the items. So there was a lot of mess. And how many of you in the room are therapists? So for the therapists in the room, this was and nurses, because the nursing community really appreciated this as well. This is an approach that gets away from, is that patient 25% impaired, 30% impaired? Instead, it looks at more of the resource issues. So can you set them up and walk away, or do you need to stay and supervise for their safety, or do they need help? If you don't need to stay and supervise, do they need help with more than 50% of the task, or less than 50% of the task? That's the difference between the 2 and 3, or are they totally dependent? And moving to a scale like this allowed us to put patients, spinal cord injury patients who might be in a long-term care hospital, on the same scale as the ones that are in a rehab hospital, on the same scale as the similarly impaired but not as intensively impaired that might be in the skilled nursing facility or getting home health. So it was kind of important. As I mentioned, we had input from all the different, we had like 25 different provider associations and open door forums. Dr. Ottenbacher was on several of my technical expert panels, presentations at the different meetings, et cetera. Because CMS and Congress recognized that you need standard language in order to both improve that coordination of care, that pass-off, as well as create data exchangeability. All of these hospitals and physician offices that are trying to set up their electronic health records and have funding through the ARA legislation are working very hard to be able to exchange data, to send that discharge transfer summary electronically to somewhere else. But in order to do that, the other place also needs to be using the same language. There's a lot going on in the IT community to allow my IBM to talk to your Mac. So it doesn't matter whether you're using Cerner or Epic or whatever. If you can get tied into the IT community, you can have the HL7 underpinnings to allow you to exchange that data and make that transfer communication. So CARE, just briefly, this was a big deal. How do you standardize items without really changing the whole world? Well, there was agreement across all the different clinical communities that there are a set of core items that you need on every patient who comes in. And then there are other items you need if the patient has a condition. So we set things up in terms of core on everybody and supplemental. If you have a condition, let's all use the same language to measure that. And then the items needed to be tested for reliability, because if they worked fine in one setting, but when you applied them to another setting, you didn't have the same results 95 out of 100 times, then you didn't really want to incorporate them in any of the rules. So we did a couple different types of inter-rater reliability tests to make sure that the item, when used in a different setting, worked the same way, that they were reliable as the items that were currently on the existing assessment instruments. The results, we had substantial agreement in and across the settings, so that was the first test. Can we go on? The second issue was, what happens if a nurse is measuring that patient versus a PT or an OT? Are you going to get the same answers? And everybody, each of the different clinical communities recognize that their training is different and the way they look at a patient is different. So the answer, I can tell you right up front, is no, you won't get the same answer. So the question is, how much did they differ? Because if you know how much they differ, then you can take that into account when you're thinking about outcomes and who is assessing the patient. So that's step one. Were they reliable? Yes, they were reliable. In the report to Congress, CMS, it was actually CMS's report to Congress, showed that you can use uniform definitions and measures of patient acuity between the different settings. And there are lots of arguments about site-neutral payment. And does that mean you're going to pay me, a rehab hospital, the same way you're going to pay that SNF for that stroke case? The answer is no. You're going to measure them the same way, so you know how similar or different they are in terms of resource needs, but you don't need to have the same payment method. So it's hard to read, isn't it? I thought the orange against the blue would work. There are a whole series of reports on the reliability of the standardized items. For those of you that are into measurement, you can find those. But let's talk about the outcomes. What did we find when we used that standardized instrument and went into the acute hospitals, the LTCHs, the rehabs, the SNFs, the home health, and tried to measure the complexity and the outcomes of those cases? So the demonstration was 2 to 3 years long. We collected data in over 200 providers from each of those different levels of care. The sample was geographically diverse because we know practice patterns differ across the country. And we wanted the PAC markets to vary. We wanted to be able to answer questions like, what happens if that stroke patient goes to a SNF rather than an IRF? To answer that, you have to be in markets that have IRFs and markets that don't, and to be able to measure the patients the same way in order to look at the outcomes. So we're very careful in selecting the markets so that they did vary in services. They varied in whether they were affiliated, whether the post-acute care entities were affiliated with the hospital, because again, you see differences in practice patterns depending upon whether the hospital has a unit or it's a freestanding, and differences by provider size, differences in resources that are available depending upon the size of the provider. The rural and urban markets, as you all know quite well down here, I'm sure, differences in access to services. We collected over 53,000 assessments, which is a pretty sizable sample to be analyzing in order to answer some of these driving questions. So just to give you an idea, we selected markets that were spread out across the country. We had a 2-hour radius around major cities from Sioux Falls up to Boston. So the size of the city even varied. We had so much interest that a lot of providers were disappointed that they weren't involved in the original, and Congress authorized us to collect on supplemental markets. And geographically, they say, a picture's worth 1,000 words. It looks like it's empty here in this part of the country, but there are a lot of mountains in there. So when it comes to people, we didn't miss too many people. So as I mentioned, we had over 53,000 assessments that went into the analysis. They were pretty well spread across the different levels of care, and we had a sizable number of providers in each of the types. We were charged with looking at 3 constructs. Resource intensity. How do the resources that go into a patient differ depending upon the site of care? What's the difference in nursing intensity in a long-term care hospital versus a rehab hospital versus a skilled nursing facility versus a home health agency? Everybody can guesstimate it, but there's been no empirical evidence. So we were charged with looking at routine intensity and therapy intensity, and separately. Also the outcomes. How did the self-care skills change as a result of where the patient went for services? How did the mobility change as a result of services? And how did readmissions differ? And then last, discharge destination. And we weren't predicting discharge destination as much as profiling the populations that were using the different settings at that point in time. And having standardized assessment data let us examine patient characteristics in a pretty broad way. So we were able to look at the primary discharge diagnosis. Well, you guys do that all the time. Ken's built a whole world around what happens when they're discharged after COPD versus a joint. Comorbidities. How does the other related or unrelated diagnoses affect their costs and outcomes? Days since prior admission. So we were controlling for how long since they were admitted to the hospital are we seeing that patient in this analysis. Cognitive status, as we all know, impairs the ability for functional outcomes, so it's an important piece to control for, as well as many of the functional impairments. Bowel and bladder management has a big impact on function outcomes, swallowing disorders, communication deficits, respiratory impairment. Respiratory is pretty important across the board in these populations because many of them have medical complications along with whatever other complications that are associated with respiratory. Mobility endurance, kind of a nice proxy for frailty. How much endurance does this person have? We had both mobility and setting endurance in the models originally, but as you might expect, they're highly correlated, and we took sitting endurance out, thinking that the mobility might be more important. And one of the most important is function at admission, because if they weren't able to walk before, they certainly won't be walking after, in many cases. I defer to my clinical colleagues to correct that. So resource intensity, this was a pretty big undertaking. We did a staff time study in each of those 5 different levels of care, which is a pretty resource-intense activity on its own, because the staff were not only treating their patients and doing the regular reporting that was required. During the demonstration, they were also identifying when they were working with a patient, how long they were with that patient, and the types of activities for a 2-week period. So we had observations on over 6,000 cases, which let us then build a measure of cost, if you will, that was a wage-weighted for licensure type and level estimate of the relative resources per patient. So to give you an example, if you had a PT working with a patient for 2 hours and you had a PTA for 4 hours, we adjusted those relative wages so that we knew how much, on an equivalent basis, resources were going in. And this let us answer the 3 big research questions, which were, does resource intensity vary by post-acute care setting? Does it really matter if they go to an IRF versus an LTCH? Does it matter if they go to an IRF versus a SNF versus home health? What was the change in functional status based on which post-acute care setting they went? And what was the probability of a 30-day readmission? So the first thing we did was see how well those standardized assessment items explained resource intensity. We knew they were reliable from the reliability tests, but how much did they really explain? When you're doing analyses, how many of you have used claims analyses in your work? Okay, so you're using data that tell you a bit of the picture. They tell you why the person went into the hospital or why they're getting treatment, but it doesn't go very far. So the question here was really, what happens if we can add information about skin integrity, comorbidities you can get from the plates, mobility impairments, et cetera? Do we really explain that much more variation? So we broke it into the 2. Routine being the nursing, the case management, all of the non-therapy services, and the therapy resource intensity being the PT, OT, and speech. So the first column, the setting indicator, shows how much variability you could explain in the resources just based on putting in a variable of LTCH or IRF or SNF. And you explain quite a bit, but that's because the payment policies have mandates. If you're going into a rehab hospital, you're giving them 3 hours of therapy. So there isn't going to be a lot of variability there. So we said, what happens if you take that setting indicator out and we just put the standardized assessment data in? Well, now we're explaining on the routine almost 70, over 2/3 of the variation in resource needs. So that was pretty exciting. It's very high. If you look at the prospective payment systems, you're usually explaining 10 to 30% of the variation. So we're like, great, we've dealt with that routine charge issue. On the therapy resource intensity, we were able to explain about 25 to 35% of the variation. And that was pretty respectable. As I said, the PPSs are all based from the 10 to 30%, so that wasn't bad. When you put them both in, put the setting indicator, it went up a little bit, but not much, which tells you you can measure case mix differences based on patient assessment data. So that was really important. So then we asked, how does intensity differ by setting? And here, for the first time, we actually had information on the same patients using the same case mix across settings, and we could say, yes, when that patient went into an LTCH, there were 5.5 units of resources. Again, this is all wage adjusted, so think in terms of relative scale. But when they went into a rehab hospital, 4.2 units per day. The SNF was only 2 units, so half as much routine resources in a SNF as in a home health. But when you took it out to a stay basis rather than just the resources per day, things even out a little bit more between the IRF and the SNF. They're not equivalent. You still have higher nursing. A rehab hospital is an acute hospital, and they have different mandates. But it was nice to be able to quantify some of that. And similarly, we did the same thing with the therapy resources. How do the different settings compare? A lot of the arguments in the payment world have been, shouldn't that patient just go to a SNF? It's a lot cheaper than an IRF. And so we had to say, do they get the same services, and are the outcomes the same? And here you can see, per day, they aren't getting the same services. You're getting twice as much therapy in an IRF as you are in a SNF. But when you look at the stay, the SNF stay was about twice as long as the rehab stay. So overall, they're getting almost the same amount of therapy intensity, although the acute IRF is still giving a higher level, and it is the highest as you would expect given the way the systems are designed. So then we asked, what about the patient affects the level of resources? And I think the big take-home here is that function's pretty important. It didn't matter which setting you were in. The self-care and the mobility came up in the top 5 for every setting. The LTCH, the SNF, the rehab hospital. Of course, the LTCH is treating the most medically complex, so you see other factors that are related to that taking the lead. This was using a cart analysis, so a classification algorithm approach that has you look at the association between 2 different variables, and rather than having every variable assigned as only a continuum, it allows you to identify the threshold at which that answer might change. So we were able to break out different ages, different types of comorbidities, and other factors using this methodology, which then shows you that you have different populations as well as different resources per case. So when you're looking at the IRF model, you see the sitting endurance as pretty critical, as well as in the SNF. But the degree of impact, and the degree of impact is similar. It has a higher resource intensity score in the rehab than it does in the SNF. This is just a nice way of leveling the playing field, if you will, and looking across settings and intensity. So what does it tell us about the patients? Are the same patients going into each of the different settings? Well, the red dot is the mean, and you can see at admission, self-care, ADL at admission, it varied. Home health had the most able-bodied people. LTCHs had the most impaired people. SNFs and IRFs looks pretty similar upon admission, but look at the distributions. So you have more people up here in the IRF and more people kind of down here. Not really telling, is that really a significant difference? So what was the impact of change? Again, here are your means. On average, they were close but different. The distributions were overlapping but different. And so what does this tell us? It tells us that there are differences between the populations that go in. There isn't a yes-no answer. You can't just say a SNF is better than an IRF or an IRF is better than a SNF. It really comes down to the case mix. So those were just bivariate, what happens looking at each setting. This puts together a model that controls for those factors that we looked at in the card analysis and asks, what is the impact on self-change? And the referent, the comparison category, is the skilled nursing facility because they're kind of in the middle of the road. They're taking rehab cases, but they're less intense than an IRF. They're taking the same medical cases, but unlike home health, they're providing 24-hour nursing. So we use them as the reference category. And we saw that overall, when it came to ADL improvements, home health agencies did the best. A 4-unit change on an average of 12 is like a 35% improvement relative to The IRF was only 3.75 on that relative to the 12 points. The LTCH had no significant change. This is all relative to the SNF. So in interpreting it, the IRF is having a statistically significant better outcome in self-care than a SNF, as is home health. But you see these factors differ when we start looking at different subgroups. So looking at the musculoskeletal or largely the ortho patients, home health still had a better outcome than a SNF, but the IRF differences were less obvious. But when you look over here at the stroke cases, you see just the opposite. The IRF made significantly greater improvements in self-care than the SNF, although home health no longer had such a big impact. So, and there are all sorts of analyses like that in the report, looking at the big take-home is the case mix matters, and you don't want to make a blanket statement about either the costs or the outcomes of any of these cases in post-acute care. And there are all the many lengthy reports if you want to comb through. So how are these results used? Well, that's kind of the big take-home. There's a whole national discussion going on about accountable care and bundled payments and medical homes, and everybody's trying to figure out, where should I let my patients go, and does it matter? Is it going to, the finance guys know that it matters to their bottom line, but the clinicians want to make sure that it also matters to the patient and that access isn't impeded. So CMS is using this work on the standardized item reliability and the impact of the site of care on use to answer some of these questions in the Medicare program. But the Medicare Payment Advisory Commission is also building on this work. They're kind of CMS's gadfly in some respects. They tell CMS, they tell Congress, you should pass legislation to tell CMS to do X, Y, Z. So MedPAC is using these findings to talk about site-neutral payments and to talk about the importance of standardizing assessment, some of those things that when you're inside a large agency like CMS, it's kind of hard to move things forward. CMS is using the results to develop setting-agnostic quality measures. So all of this attention on readmission measures is actually coming to the forefront, and they're saying, oh, we can get at some of these results by using consistent language. And data can be used to ensure access to care, to appropriate care. So that's in the quality metric world where they can issue regulations. But stepping back even further, Congress has just issued some testimony, which Ruttenbacher, I forgot about the May 21 hearing. Congress has been debating the issue of whether they should just move the standardized items into the existing assessment tools so that you can, on an ongoing basis, measure the complexity and the outcomes of the cases that are going into the different settings and ultimately refine the payment models to reflect the costs of the resources needed to achieve those outcomes. So there's legislation out there right now. The impact bill was kind of different than anything I've seen in a long time, and that is because it was put out by both the Senate Finance Committee coupled with the House Ways and Means Committee, and both the Democrats and the Republicans were behind it. So you had a group of 4 very different sets of members who typically are fighting with each other, all working together saying we need to standardize assessment items. It also had many other pieces in there, directing MedPAC to do a report on, CMS to do a report on some of the costs associated with it. After 2 years of data collection, MedPAC doing some work to refine the payment models, et cetera. So it's a very interesting piece of legislation, and you can go out to Ways and Means Committee and Google on impact of the bill. But there's also a lot more work associated with all of this. If you think about the different populations that we saw in the LTCH versus the IRF versus the SNF, that LTCH group has the most complex, most medically complex, and we lovingly call them the chronically critically ill. They're usually your end-stage COPDs, they're your messy trauma cases. 40% of those cases leave the hospital because of death rather than improvement. So they're pretty critical, but they're also treated in the acute hospitals. And so a very related question to all of this is, Well, if you're paying, $8,000 to stay in the acute hospital and $35,000 to stay in the LTCH, what's the cost-effectiveness ratio there? Is there a difference in the outcomes if the chronically critically ill are treated in an acute versus an LTCH? Is there a difference? Yeah, we know there's a difference in the cost. So there was a whole piece of work looking at the chronically critically ill populations in the acute hospital, just like Ken's team is looking at the rehab populations by looking at why they were in the hospital. We looked at why these CCI cases were in the hospital and whether they went to an LTCH or did not. What was the difference in the cost per case, in the outcomes per case, the mortality, as well as the return to community, et cetera. A very important area, and in fact the work that came out of that led to an increase in the payments for the hospitals that were treating these populations, because when we looked at the margins, both groups were actually losing money. Now, there are additional cases in the LTCH that aren't CCI, and they did not get a similar bump up. But if you think in terms of the case mix, you can identify which cases need adjustments to their rates in order to create access to the appropriate care. On the other end of the spectrum, the outpatient therapy. So you have all these Part B bills happening in the therapy clinics, in the hospital outpatient departments, in the comprehensive outpatient rehab facilities. There are about 6-7 different settings where Part B services are provided for therapy. And CMS wanted to understand, should we be paying them differently, recognizing case mix differences for the costs of the cases. So again, building on the care standardized data and building on some of the work that colleagues at DU have done with the self-report assessments, the AMPAC work. We looked at, in the community-based populations, are there differences in the number of visits provided and the outcomes achieved? In complement to that, a lot of Part B goes on in the long-term care nursing facility beds, so not the short-term, but the long-term, and we had them in the study as well. And as I mentioned, we've been working with CMS on setting-agnostic quality metrics. So it doesn't matter where that patient is. If they have a pressure ulcer, there are certain never events that should be independent of site of care. So really starting to think in terms of the patient and developing quality metrics and not just the setting. And it's also affected a lot of the discussions about classification criteria. In the inpatient rehab hospitals, you have the 60% rule, or some years you have the 75% rule. It goes back to determining whether a rehab hospital is going to be paid as a rehab hospital or paid the lower acute care hospital rate for that type of patient. And it comes back to the proportion of patients that you have being admitted to your hospital rather than actually basing it on the complexity of the patient case. So there's a lot of work that once you can measure case mix complexity in a reliable way, you can affect a lot of these payment systems. The last piece is the care prototype, because while the clinical issues are very important, so are the IT issues. So CMS has been working with the IT communities. Are any of you into IT? Do you have any of that? All right. There's a whole group called the Standards and Interoperability Work Group. They're basically engineers from big computing groups that are working. They were kind of capitalizing on the R legislation that was leading to the electronic health record development in hospitals. But CMS has been working with them on the post-acute care standards and on building standards for these patient characteristics that can then feed into all of the different EHR systems. It's kind of an exciting time. That's just my contact information if you had follow-up questions. But I think we have time for questions, if anybody would.
So just a follow-up on the congressional testimony that you did. So in the care tool that you talked about earlier. So what's your guess about how that will end up being used? Well, obviously, as you said earlier, there are different the different post-acute care venues already have their tools that are in place, and so it's hard to replace those. But gradually including the items from the care tool, or how do you see that going forward?
One of the key issues in thinking about these issues is to minimize the burden on providers and delivery systems, because the CMS isn't interested in creating more chaos. They're interested in contributing to this patient-centric discussion. So over the last few years, there's quality metrics that are in place in the silo-based quality programs. The items that are being used are the standardized items. So in the NDS or IndyBirth Pie, you would have seen a couple of years ago they pulled out the push tool that was used to measure pressure ulcers, and they replaced it with the standardized pressure ulcer items. So now you have the same language of both the rehab hospitals and the SNFs, and they did the same thing with the OASIS, with the home health assessment. Because each of the systems not only use that data, feeds into the case mix groups, but it also feeds into some care planning. And they don't want to disrupt those systems. They want to let that process work, but they want standardized information on case mix complexity items. So it's already started, and this work with the IT community is creating an additional resource where CMS typically puts the every time they change one of these tools, they run training for all the clinicians that have to use them, and they put the specs out so that each of the provider communities can download the specs without having to hire a vendor to develop all the IT, et cetera. So in combination with the specs, they're also starting to put out the point codes and the interoperability standards. So it's kind of exciting. I mean, things are going on and they're doing it in such a way that it won't be as disruptive, but it will achieve the AAA. It will achieve the ability to compare your hospital to the hospital next door. And in fact, one of the pieces that I was asked to testify on the Energy and Commerce Committee was whether hospitals should be involved in the standardized assessments, or can't they just go on their own? You know, they've been cranking out these readmission models since all of the new payment incentive programs have gone into place, and why make them move to the standardized assessments? Well, because that's where the care starts, and half of this coordination is improving the communication of the clinicians working in the alternative setting. So if they're not using the same language to describe the pressure ulcer, you still aren't going to achieve that better health, lower cost. Yes.
You mentioned that you looked at whether the hospital owned the inpatient rehab center or where it was a standalone. Did you see, were you able to detect any difference in the level of care between those? I'm kind of getting at, there's a lot of work going on right now in Texas because of our 1115 waiver about coordination of care across the continuum. And we have a lot of care managers and that are working out in the community and navigators.
Yes.
Does that make a difference?
Yeah, does what make a difference?
Having the coordination of care, and having the hospital be the active, an active partner.
Yes, the active partner is very important. You know, I left one of the initiatives off. We're also working with the Medicaid group at CMS to bring the standardized assessments into the Medicaid-funded LTSS initiatives. And there are states like California where, independent of whether they're participating in the 1115 or the balancing incentives or the TEFT or the SIMS grants, they are mandating that their assessment items be consistent across all of the state-funded programs for those populations so that you can exchange the data. So you don't have a person going in for social support services collecting the same information as the person being admitted. You already have just transfer the data. So does it matter? Yes. It's about communicating across all of the parties that are working with that person. And I'm happy to talk with you further about that. Are you guys, you run the balancing incentive states, right?
No, I'm not familiar with the balancing incentives. We've got some demonstration, long-term care, moving into community-based care, trying to
The
change
dual
those.
eligible demos?
A big break.
Is it the dual eligible demos?
Yeah.
Okay, yeah. After this, we'll talk about it. So you can see there are a lot of different initiatives, with different funding streams, all coming out of, well, I say different funding streams. CMS has both the Medicare program and the Medicaid program. There are a lot of different stakeholders. Each state has its own Medicaid program and benefits. While there are core benefits that are common across the country, there are other benefits, and there are different thresholds of eligibility levels. So having everybody at the table as we talk about content measurement, the language, as we talk about exchangeability of data across the CERMers and Meditex, the ethics, everybody's using their own thing. As we talk about comparable populations, as we talk about even broadening out with the 1115 and the duals, they're starting to bring in the local community-based resources. So groups like the Area Agency on Aging, who historically has been left out of the discussion, but they're the ones that know when that person's looking for an informal or formal caregiver. And that caregiver, the research has shown, you can reduce the likelihood of a hospitalization if somebody's checking on that person every day. So it's like the whole world is moving towards patient centricity, person, when you start talking about the long-term care population, centricity, and not their respective silo of business. Very exciting. Other questions?
Okay, well, thank you very much, Barbara. Thank you.
Thank you so much.